Good morning or good afternoon wherever you are. I'm Benjamin with the EMT Booster. And today we're going to be doing a final exam review for the FISDAP. This will be preparing you for the readiness tests so that you can have the best opportunity that you can at passing them. So what we're going to do here is first we're going to review the quadrants. So there's a pretty good way of remembering it, and I think it was like Always Sexy and Palm Beach sexy or some shit. I don't know. I'll go over that towards the end of the video. But the big things you need to remember is gallbladder can have referred pain to the right shoulder, and the pancreas can have referred pain to the left shoulder. No, sorry, spleen. My apologies. Alright, so we're going to move over to the review. So what are the respiratory rates when we should consider a BVM? How do we determine adequate respirations? So 8 respirations per minute for an adult, and skin signs and anatomical signs. So if someone's pale, cool, and diaphoretic, you've really got to see what's going on, because that's obviously the ABCs are compromised at some point there, because the body's naturally red and breathing fine. So along with the anatomical, if you've got like JVD, any sort of like cyanosis, that kind of stuff, that's where you'll start getting into those anatomical signs. So understanding the epidemiology of audible differences with your lung sounds. So wheezing is constriction of the bronchioles or small structures. Air being forced through small air passages that are constricted. It's a fine and musical sound. You can generally see these things with asthma. Bronchi is constriction of the tracheobrachial passage, slash air being forced through large passages that have been constricted. Coarse and loud sounds such as COPD and pneumonia. So rales is generated by small airways snapping open on inspiration. You can also hear the sound on expiration. So if it's coarse and fine, that tends to be the smaller passages. If it's a deeper pitch and coarse crackle, that's going to be your larger passages. This is generally seen in congestive heart failure, specifically your left-sided heart failure. Stridor is an airway obstruction. This can be due to, the person's tongue, which is the most common foreign body, or a true foreign body like a piece of food. You can also see this when the patient is in anaphylaxis and they're becoming constricted in their upper airway. Corrective action if we no longer see visible chest rise while performing positive pressure ventilations, so readjust the airway. If you are not seeing someone's chest rise and fall, or seeing tidal volume, that is pretty easy to assume that there's a compromise in the AB portion of your ABCs. Especially if you're not seeing like distension from the stomach. But yeah. Oxygen flow rates, so for your nasal cannula, it's going to be 1 to 6. Non-rebreather mask will be 10 to 15. Your BVM will be 10 to 25. And nebulized treatments will be 6 to 8. And always remember, you were talking about liters per minute. You're not talking about any sort of other measurement. Because the big thing is always you want liters. You don't really care about anything else. Airway obstruction knowledge. Witness patient collapse. What should your first objective be? Determining if ABCs are compromised, or readjust the airway. What to ask and how to approach a patient who is possibly choking. Are you choking? Ask to cough, present self. So you walk into a restaurant, you see a 45-year-old male choking on a piece of steak. What you should do, walk in. If the patient is conscious, you should ask, hey, are you choking, sir? If they simply yes, and before any of that, make sure you present yourself. Make sure you're not like hiding behind something or you're behind them. You always want to present a patient from the front, because that will provide additional security and won't surprise the patient, which can make the situation worse, specifically in a choking environment. So yeah, when do you simply encourage a patient to cough? That's a partial obstruction, so if they're still able to breathe or talk, you'll generally hear stridor in these circumstances, and that will be when you encourage your patient to cough. How to treat a patient with a stoma that is not receiving adequate respirations. So you cover the stoma with a fitting mask, which can be PED, and oxygenate. So the big thing with that is a lot of stomas will have an adapter for your BVM, so you might not necessarily need a pediatric mask, but if the patient does not have a guard to their stoma, then you're going to generally have to have a pediatric mask. It's just making a formed seal on the area so that the oxygen goes straight in. When to consider using humidified oxygen. So when the epidemiology indicates the illness is exacerbated by cool or dry air, this will present like most majorly in like croup patients in your pediatrics and or long transports. So if the patient has croup in their, the seal-like bark cough, the whole nine, you can actually even in some cases just have the patient take a shower or go outside and their symptoms will almost disappear. So it's really, for stuff like croup, can really help out the situation. And long transports, if you're in a metropolitan area like LA, Orange County, you're generally not going to have to worry too much about long transport times. But if you're in a more rural place like Erie, Colorado, or um, like Estes Park, you're going to probably end up doing some longer transports when the situation is not necessarily able to be fixed with your general hospital. How to ask questions to a patient with extreme shortness of breath, what to ask and when. So you're going to ask yes and no questions. You want to ask questions that will help give you more information about what's exactly going on, because shortness of breath can mean many different things, and it's very effective to just ask patient yes or no questions, because the more you make them talk, the more they're going to have issues, and obviously shortness of breath is a compromised ABC. So once you've ensured that the airway is patent and they're obviously not breathing well, so you're going to have to go after the, ventilations. So yeah, you want to give them at least a non-rebreather mask at 15 liters, but if the patient is breathing too fast and shallow, or breathing too slow and shallow, you're going to generally want to hook them up to your BVM at the most you can do. A lot of tanks will only go up to 15 liters, but if you have 25 liters, give them 25 liters, because oxygen really doesn't hurt in a situation where someone's not breathing or having very bad dyspnea. And dyspnea only means that they're having difficulty breathing, whereas apnea means the patient's not breathing at all. So NPAs versus OPA, when are they indicated, when are they contraindicated? So an NPA is contraindicated by head or facial trauma, specifically to the nasopharynx. It's indicated when the patient has a gag reflex or is semi-conscious. So if you respond to a call, the airway is compromised, and you need oxygen into the patient, you give them an NPA if they don't have any facial trauma. An OPA is contraindicated by a conscious patient or intact gag reflex, and facial trauma specifically to like the oropharynx. It's indicated when the patient has a tongue obstruction or has issues maintaining their airway. When to suction a patient and what suction catheter would be best for the oropharynx. So a rigid catheter when the airway is compromised by fluid or throw up. So throw up's also known as emesis, and if the person they're throwing up, they're getting themselves all nastied up by that, you generally want to get them sucked out so that the airway is patent and they can breathe once more. So signs and symptoms of spontaneous pneumothorax versus attention pneumothorax. So in both, You will hear diminished lung sounds, well, specifically spontaneous, unequal chest rise, JVD, tracheal deviation, and absent lung sounds tend to be the later symptoms of a pneumothorax. And the best way to remember it is spontaneous. That basically means, yes, the lung is punctured and the pleural space is filling with air, but it hasn't gotten severe enough to the point where it's a tension. And another thing, I guess, that will help, there are two different types of thoraxes, like the pneumothoraxes. There's the hemothorax, and then there's the pneumothorax. Pneumothorax is when air begins to fill the pleural space, resulting in pressure in the lungs, which, when you get to the point of like tracheal deviation, that means that there is legitimately, the lung is pushing onto the heart. It's pushing all that pressure up into the trachea, which is starting to get deviated, and that's a very severe later sign of attention pneumothorax. And in tension, you're almost always going to hear absent lung sounds. Um, so yeah. Signs and symptoms of pneumonia and its epidemiology is a fever, productive cough. You'll generally see I believe it's called like infected sputum, which is basically like your brownish, yellowish sputum. Bronchi in the lower lobes of the lungs, normally on one side, but if the infection has progressed to the point where it's infecting both sides, it tends to be in more severe cases of pneumonia, and all this is an infection of the lung. So signs and symptoms of chronic bronchitis and its epidemiology. So there tend to be cyanotic, bigger and pursed lip breathing. So this is your, I think they're called blue floaters. These tend to be your bigger patients. So yeah, um, yeah. So the difference between systole and disystole. Systolic is your high. Is the pressure on the contraction of the heart, and diastole is the low. It is the relaxation of the heart. So basically, systolic is the pressurization of the arteries from the heart, and the diastole is the relaxation of the heart and the arteries. But the arteries always retain some sort of pressure when the patient is alive, so that's where the blood pressure will always be, at least somewhere on the diastolic side. If a patient, not always, there's no certainty in medicine, but generally, if your patient has a heart rate, they're going to have a diastolic. Um, if a patient regains their pulses after the use of an AED, what do we assist him? So rescue breathing, ABCs, and ventilation. Another way that people refer to it is ROSC. Um, so just whenever you hear that, you know, that's how you know. So what are the major contraindications for nitroglycerin? Um, so the biggest obviously being, since this will be a vasodilator, well, a coronary vasodilator, you're generally going to want to avoid a systolic of 90 or below. If it is that, then you're going to be pretty off. Pulmonary vasodilators and sexual enhancement drugs, and more than 3 usages of nitro. That is per the National Registry, not per specific counties. I know in Orange County it's normally like 3, but I've heard in like Los Angeles County it can be as high as 5 usages of nitro. For EMT level, paramedics are a completely separate breed. Um, so just cool fun fact of the day. Pulmonary vasodilators, sexual enhancement drugs like Viagra actually started in the hope of becoming pulmonary vasodilators. So just because the patient is not a male, they could be taking a sexually enhancing drug for the express purpose of a pulmonary vasodilator. And yeah, that's where you can see geriatric females taking them to help with their pulmonary vasodilation. I'm not 100% certain on this because I'm not a female, but I've heard that it can also help with enhancing the pleasure sensors for the women. So that's also entirely possible. And don't be afraid to ask If a person's calling you there, they're generally not going to hide from you that they're taking Cialis, all that. And just one more thing. I know I said ROSC earlier, and I didn't give a proper definition. ROSC simply means return of spontaneous circulation. So all that means is the heart has begun to beat on its own once more. So when dealing with a possible stroke patient, what questions are important to ask? So onset and last known well are by far the most important that you need to know, because if a patient just had a stroke, you need to know how long it's been, because if you get them to the stroke receiving and you can relay that information, they can get life-saving medications, and the definitive care can actually allow for them to return to a normaler status and possibly no deficits. So that's very important. Another big thing is if a patient has had a medical history of a stroke before, you want to know their deficits, because if they do have deficits, that can be a very big helper, because if you respond to a call and they're presenting with right side deficits and signs of a stroke, and they had a stroke previously and they had deficits from their stroke on the right side, that can help, but obviously it's always good to err on the side of caution. And then the Cincinnati stroke scale. I know every place has different stroke scales, but the most universal one that most things are built off of is the Cincinnati stroke scale, which will use arm drift, facial droop, and various other ones, along with grip strength. So the big things you should do is if you come on scene and you've got a patient who has no grip strength on the right, they have drift on the right, and they have facial droop on the right, they've probably got a stroke. So you're going to want to transport them to your nearest your nearest stroke receiving center. When assessing a patient for agonal respirations, what is the course of action? Determine ABCs, life threats, and treat airway automatically with BVM. Agonal respirations are always ineffective. And generally in when you see this, especially in trauma victims, it's not a very good sign. When you see agonal respirations in a trauma victim, that normally means they're getting to the later signs of whatever they're experiencing, and it generally is not very good at that point, and it's very bad. Obviously, if there's any sort of compromise to the airway, you always want to start with what is best. BVM being the most invasive, and nasal cannula being the least invasive. But in situations where it is a life or death situation, you want to be doing what will help them the most, not what is the least invasive. So how to position a patient that appears to be in shock, supine and Trendelenburg. So if you're doing JBL, I think it might have said Trendelenburg, but I believe ACLS is saying now it's supine. This always goes back and forth. Either way, if you can get the patient to lie down, that's probably going to be the best that they can be in. Which chamber of the heart, when in failure, is responsible for causing pulmonary edema? That will be your left-sided failure. And the best way to remember this is the left side is the biggest part of the heart, and that normally will go first when it comes to cardiac failure, because basically that's the big portion that pumps everything through. If you don't have that, then you're not going to have anything else. The left goes straight to your lungs, so when it is not providing adequate pressure, that will result in your lungs filling up with a liquid, specifically blood. I will go more into that once we get down to the congestive heart failure section. Physical signs and characteristics of heart failure. So a right-sided heart failure will result in a pedal edema. That will be when you compress onto a person's foot or tramp stamp area or their wrists, I believe, and it will be very sluggish and slow, because even with fat people, when you press into their body, it will rebound right back. But with them, it will, since there's a fluid in the tissue, it will take a while to return to its regular elasticity. JVD, jugular vein distension, generally with your SOB or your left-sided failure, that's where you'll be seeing that. So yeah. The two shockable arrhythmias on the AED will be your ventricle tachycardia and ventricle fibrillation. As an EMT, those are the only ones that you need to know, and you generally won't be reading an AKG or using a defibrillator, so it's going to just generally be the AED advising a shock. Ventricle tachycardia pulseless and ventricle fibrillation pulseless are the only ones that you can shock. If they have a pulse and their ventricle tachycardia, then that's going to be a problem. Also, ventricle tachycardia will be pretty rare to see on scene because normally by the time you've been there, they've already passed through ventricle tachycardia. Best way to think about ventricle fibrillation is it's like a bag of worms firing without a leader. I think it's the SA node. I can be wrong about that, and I will make sure that I'm not in the coming up seconds. But it's basically like a bag of worms firing without a leader, and it will result in basically the heart just not having any sort of circulatory capability. And yeah, it's the SA node. The SA node controls the entirety of the heart throughout its process. It goes down to Purkinje fibers and all that. The Purkinje fibers are generally what's firing when the ventricle fibrillation, because there is no what do you call it? No electrical pulse coming from the SA node regulating the heart. And the full process goes from the SA node, AV node, and then the Purkinje fibers. Right here, my apologies. So the SA node is known as your it is known as your sinoatrial node, and your AV is your ventricle node, and then your Purkinje fibers are Purkinje fibers. So that is just a quick synopsis of the heart. The vessels that carry oxygenated blood versus the vessels that carry deoxygenated blood. Hint: all vessels flowing away from the heart are arteries. All vessels flowing to the heart are veins. So arteries carry oxygenated blood generally. Exceptions occur in the pulmonary section. The pulmonary will be deoxygenated, going away to the lungs, and the veins will be oxygenated coming to the heart. Big things to come here too are pregnant patients. You will be seeing your umbilical cord, and that will be another situation in which the artery has an inverse position. But that is not in general patients. That only occurs when you are talking about the umbilical cord between a pregnant and a fetus. Signs and symptoms of an ischemic stroke versus cerebral vascular accident, TIA versus CVA. TIA resembles a CVA in every way excluding duration. TIA is due to a buildup of a thrombus or embolus, which results in a brief clot of the brain, resulting in no long-term effects, but warning sign to a major CVA going to occur. Treat the same and get them to a stroke receiving center regardless. Signs and symptoms and epidemiology of cardiogenic shock, failure of the heart, decreased blood pressure, decreased blood pressure, high heart rate. My bad there, guys. Sorry. This comes from your CHF patients. This can come from trauma when you have severe trauma to the chest, and an AMI, or acute myocardial infarction. AMI is the same as a heart attack, but it is the more medicinal term that you will be using when talking to doctors. Subarachnoid hemorrhage. Blood fills the cavity between under the pleural space. Sub being the below, epi being the above. Systolic goes up, irregular respirations, decreased heart rate. This is also known as the Cushing's triad. Cushing triad is basically where the systolic goes up, the diastolic stays similar, the irregular respirations occur, and decreasing of the heart rate. And this is generally what you'll see when there is increased ICP in a patient, but you can also see it with just head trauma, and head trauma can also be very indicative of ICP. So yeah, and I will go more into that in the addendum section when I start talking about posturing. How the patients will present with left-sided heart failure and what their chief complaint will be. Shortness of breath, there will be crackles, red sputum, and frothing red fluid. So not in all patients will you see frothing red fluid, but red sputum is generally a pretty good indicator, and crackles is also another great indicator. Sequential steps for initiating cardiopulmonary resuscitation. Primary assessment, AVPU, LOC, ABCs, life threats. So when you've assessed that the patient does not have, they're unresponsive, they aren't responding to your pain, they aren't awake, and nor are they responding to verbal, then you can obviously do your LOC. ABCs, obviously your circulation is compromised. We will get into that once we get to the diagnostic steps. ABCs, you'll generally also, we'll go into that. And life threats of someone's hemorrhaging or whatever. Attempt carotid pulse, which is your neck, the Hollywood one, and assess for respirations. So this should be done in one fluid movement to allow for the most optimal amount of high quality compressions. Because the less time you take diagnosing, the more time they get high quality compressions, and the chances of them surviving goes up. Because I believe it's 10% chance of survival in an AMI with only CPR, and 20% in hospital care. So it's very important to get that compressions on, because that brings up their chances from 0% all the way up to 10%, and that's a very, very good deal right there. Alert ALS, prepare AED while beginning high quality compressions. If you're in the civilian world and you are alone, or whatever, just alert 911. Preparing the AED, get someone to get the AED, and alert ALS. Your first priority is to get the compressions, because compressions save lives regardless. In the EMT situation, you will proceed to complete 30 respirations at 100 beats per minute, then giving 2 rescue breaths, preferably through VBM at the highest liters that you can do. Repeat for 2 minutes while following AED commands. The AED will say, trying to find rhythm. You'll stop for like 15 seconds, it'll find the rhythm. Then you will proceed to continue CPR. Once the shock is advised, you will proceed to CPR until shock is ready. You will learn this in the BLS section, obviously, of your AHA BLS. And it does, just because it's preparing for a shock and the shock's advised does not mean it's ready to shock. But once they're ready to shock, assure that the patient is clear. Repeat until repeat until ROSC is achieved. If not, switch person in charge of compressions, then repeat. If every 2 minutes or every 5 cycles, you want to switch with your person doing compressions to ensure that they are getting the most optimal compression, life-saving compressions. When treating a patient with a possible communicable disease, how should we handle our equipment? BSI gloves will be, or BSI will be gloves, mask, gowns, and goggles. Dispose of PPE and clean the rig. Generally, a good rule of thumb to always clean rig, but be especially careful. Make sure you clean with antibacterial or antiseptic materials so that you can ensure that the next patient will not be exposed to a disease. When are track marks on a patient's arm present, and what type of OD would you suspect? So track marks are due to intravenous drug usage, and that's generally because they'll put the IV in, they'll pump themselves with a drug, heroin, whatever, and it'll just fuck up their veins, because that stuff's no good. And generally, most people who are doing intravenous drugs will be your narcotic or opiate users. Contraindications before administering oral glucose gel. They have to be conscious and able to swallow, and have the ability to protect their airway and have self-management of airway. Why and when do we remove a patient from an enclosed space before treatment? Imminent danger. So if someone is in a flaming vehicle and we were talking to the paramedics during the operations section, and they were talking to us, and they were like, well, in their test, there will be a question that asks, hey, so you see a patient who's got a car that's on fire in the engine bay. Do you A, grab the patient, pull them out? Not like that. I'm paraphrasing, obviously. Or do you do A with C collar? C is, do you wait for additional help? And then D was your fire extinguisher in the vehicle. Obviously, you're going to go for rapid extrication, and you're not going to prioritize C-spine because life over limb is always what takes priority. And obviously, your safety, your partner's safety, then your patient's safety. When would we consider contacting poison control? Ingestion of poison or substance that can assist in their treatment. So, if you do not know the poison, if you don't understand what's going on, some of the best helpers will be poison control, because much like definitive care of doctors, they are a lot more intelligent than we are when it comes to poison. Next up, what is the priority when treating a patient with a communicable disease? Personal and partner safety. Signs and symptoms of possible narcotic overdose: shallow, slow respirations, pinpoint eyeballs, and snoring respirations. So obviously with this, you'll be treating with naloxone. Naloxone is generally going to be a 4 milligrams over 0.1 milliliters. You're going to pump that into at least one nostril so that they can get that life-saving Narcan into their body. With Narcan, just because a patient doesn't regain consciousness and become patent and breathing on their own again, does not mean that the Narcan was ineffective. If you see a clear cycle in which the Narcan did significantly allow for and help the person, then it's obviously doing good. EMTs are allowed to give up to 2 pumps of Narcan. Not 2 pumps, but 2 intranasal usages of Narcan. So, yeah. Paramedics obviously can do a lot more, but if it's helping them, I'll give them the second dosage, and then that should really start helping them. Signs and symptoms of internal bleeding. So this is implying all internal bleeding. So low blood pressure, bad skin signs, rapid pulse, coffee ground emesis, black tarry stool. So obviously with the GI bleed, you will be seeing coffee ground emesis if it's a lower GI bleed, and black tarry stool if it's an upper GI bleed. Obviously with upper GI bleed, you'll see bright red emesis, and then with a lower GI bleed, you'll see bright red stool. You'll also see ecchymosis, which is bruising, rigidity, a lot of that good stuff. So just generally when you see shit skin signs, low BP, just occurred in a trauma, you're going to have a pretty good idea that they're probably internally bleeding if they're not bleeding on the outside. And if you're seeing the coffee ground emesis, black tarry stool, ecchymosis, there's a lot of different reasons medically why this stuff can happen, from ulcers and all that stuff. So generally if you see that kind of stuff, that's what you're going to be looking for. So, I know that's not the most helpful when it comes to the epidemiology of a colitis. So it's gallbladder inflammation. If you're curious, occurs a few hours after eating and will result in referred pain in the shoulder. You know where your gallbladder is. That's a small digestive organ beneath the liver. I believe I went over in a prior section of anatomy, which we discussed that produces bile, which helps digestion. So yeah, there's not a whole lot you can really do as a pre-hospital care person. So yeah. How do we talk with a psych patient that appears to be suicidal. What's your plan? So, like, do you intend on hanging yourself, jumping off a bridge, etc.? Do you want to hurt anyone or yourself? So, are you homicidal? That's very important, especially in the back of your ambulance, because there are sharp implements and there's a lot of ways that someone can get hurt in the back of one of those things. And then timeline. So talk about it, man. Figure out what's going on. Obviously, it's going to be a very long, drawn-out conversation if you ask why, but ask what's pertinent to what you can do to help them if you don't care to talk to them. Signs and symptoms of and epidemiology of pneumonia, one-sided lower lobe lung bronchi, and severe cases both. Fever, dyspnea, it's an infection of the lung sacs, alveoli, causes inflammation due to fluid and pus filling up the sacs. So signs and symptoms: carbon monoxide poisoning. What may be the cause? So normal pulse ox, cherry lips, swollen, bright red skin. If you do get there too late, you might see livor mortis, and you'll see a very bright red victim. Towards the end of the video, I will do a couple Google searches on some of these things to show you what I'm talking about exactly. Next, how to extract a singer from insect sting. So a lot of people say, oh, just use a tweezer, right? No, you don't want to use a tweezer because all you're going to do is squeeze all that nasty little poison into the person. And if they're anaphylactic, that's just going to make the problem 10 times fucking worse. So what you're going to do is you're either going to get a credit card or a penny and you're just going to scrape it off. Because that way you pull the little thing out, no venom gets back into them, all good. A patient with sickle cell anemia may need what? O2 in position of comfort. There's a whole lot of nothing you can do in the pre-hospital setting, especially as an EMT, for an anemic patient. And a sickle cell anemia will inhibit the hemoglobin's ability to get oxygen through diffusion, so it's always good to give them that good old O2. How to treat a patient who presents with a heat-related illness. No water in heat stroke cases. If it's heat exhaustion, you can give them water and fluids. By the point that they're getting a heat stroke, their brain is basically fucking cooking. So what you really need to do is remove them from the environment and give them cooling measures. So there are sensitive parts in the body, specifically your neck, groin, and armpits. If you throw an ice pack there, and there, that will give them some of the most help that you can really give them. If someone's bleeding from a dialysis shunt, how and where do we control the bleeding? Tourniquet, if bad. Since a shunt is generally attached to the venous system, you're probably not going to be seeing arterial bleeding. So, yeah, you could possibly get away with putting an ABD pad on them or just letting it clot on its own. I don't know, it's very complex when it comes to that, but really you're not hurting anyone if you're just throwing a tourniquet on them. That will do a lot more help. Signs and symptoms of pancreatitis. So tenderness and pain in the upper right quadrant near the middle of the system. We'll go back right here. You'll see the midline right here next to the umbilicus. Right there, you'll see pancreatitis. So yeah, sorry, right there. And pancreatitis is obviously the inflammation of your pancreas. So when this dissects or ruptures, this can turn into pancreatitis, peritonitis, which is the perineal space getting filled up with fluid, causing inflammation, which is no good. Signs and symptoms of, types of seizures. Absent seizures are your petit mal, your focal motor, one area of the body is seizing. This is due to electrical activity or overstimulation occurring to one portion of the brain. Grand mal is overstimulation or understimulation, just electrical current hitting the entirety of the brain, resulting in a grand mal. Status epilepticus is 15 or more minutes of seizure without regaining consciousness. When you arrive on scene and a patient's still seizing, you came on a seizure call, assume that they're status epilepticus, because there is no point in assuming that they are not. So yeah, signs and symptoms of uh, appendicitis, lower right quadrant, rebounding tenderness, fever, and increased blood pressure and increased heart rate. Um, so big thing. So that's obviously inflammation of your appendix. This can come from infection and many different things. So and trauma and all that good stuff. So uh, I forget the exact term for it. This is going to be a Google question. Um, so basically, there is a point in which the appendicitis will present with Robinson sign, and that's basically where it drifts towards the point of the umbilicus. And yeah, so if you've got a patient who's presenting with a lower right quadrant with sharp pain, rebound tenderness, and Robson sign, basically they've got the umbilicus pain, you're generally pretty certain that that's an appendicitis call. When delivering a child, how do we address if the cord is wrapped around the baby's neck? This is also known as a nuchal cord. 2 fingers between the cord, slip between the neck, or clamp and cut. Always, when you're cutting the umbilical cord, clamp and clamp, cut in the middle. You want to give as much space as possible, and you don't want to cut near the neck, but in emergency situations, you have to make calls so that the baby don't die and the mom don't die. What is the role of the placenta? It is to nourish the baby. Pregnancy-related emergencies and their trimester. So ectopic pregnancy will generally present in the first trimester, and it is basically where the pregnancy occurs anywhere besides the uterus, but predominantly you will see this in the fallopian tubes. When this ruptures, this can be very bad, so it's very good to catch these early on. There's the abrupt placenta, which the placenta separates prematurely. This occurs in later trimesters, and is generally associated with trauma. This is your more painful bleeding. Placenta praeviera is your placenta is blocking the cervix. This is painless blood in its later trimesters. Spontaneous abortion, also known as miscarriage, usually by 20 weeks, this will occur. After that's generally a stillborn. How do we position a present person during transport and why? So patting the left lateral side to allow the inferior vena cava to remain uncompressed by the body weight. Because you have to remember that this person is carrying like 30 pounds plus on their body, and their vena cava can easily be smushed and will prevent blood from getting to vital organs and being recirculated. So, very bad. What signs will be present in of imminent delivery of a newborn? Certain questions to ask a mother. So, crowning, or if they feel like they need to make a bowel movement, or they're bearing down. How far apart are the contractions and how long? The longer and the closer, the more imminent. If they're receiving prenatal care, and then obviously you want to know if the doctor is suspecting any complications, because the doctor, that's free advice. You know, if you're delivering a baby and you got complications suspected, it's always going to be more nice to know what's going to happen than have no fucking clue. So preeclampsia and eclampsia, understanding the difference in how to treat. Hypertension and swelling is JVD, headache, vision abnormalities, and ringing of ears is your preeclampsia. Just hypotensive problems. And then eclampsia occurs once a seizure has happened due to the high blood pressure. Treat like a normal seizure, but observing the normal pregnancy problems. So obviously this goes back to the positioning deal, the left lateral positioning, so that you can prevent any sort of additional issues there. But it is pretty much just a seizure. The only difference is now the person's pregnant. So next we got the ruptured ovarian cyst, sharp tearing pain, lower left or right quadrants, and normally they know that they have a cyst. Pelvic inflammatory disease. That will be your vaginal discharge, bloody shows, burning pain, and lower abdomen, pain before and after sex, and normally the patient has a history of UTIs. When and why would we massage the fundus of the mother after delivery? when they are bleeding after pregnancy, and it helps stop the bleeding. How to position a mother, if only an umbilical cord is present upon inspection. Place your face down and hips up / elevate her hips. There's a lot of different ways to say this. I'm just going to say it in the most tactful way possible, but you can use whatever helps you in your head to remember this. If a female has been sexually assaulted and bleeding from the vagina, what is the best way to treat? Dry sterile dressings over the vagina and pressure. If they request a female, give them a female, obviously. You don't want to be touching them after they just got grossly sexually assaulted. Breech birth, anything other than a head comes out, elevate the hips, discourage pushing, rapid transport, no delivery, because there is nothing you can do in pre-hospital care that helps a breech birth. When would an EMT place gloved fingers into the vaginal opening during a pregnancy-related complication? Umbilical cord or prolapse cord, make a V with your hands, like Spock, and shove it in, create a space. What is perineum tearing when the baby is coming out and it either does or doesn't happen? This is basically when the shit starts tearing in the vagina. Normal respiration rates for pediatrics and adolescents. Your neonate's going to be a 30 to 60. I think it's toddlers 24 to 50. 22 to 34 for school age. Adolescents will be, so I'm using the resource called ACLS because the book didn't give me a very good answer, and when it comes to testing, ACLS will always take the answer cake because ACLS is a very informed thing. So yeah, and if you want to review this kind of stuff in yeah, so yeah. And then for your adolescents, that will be, I think it's like 12 to 16 or 18. It's pretty freaking low. So yeah, I would go check ACLS down to get your answers, just to make sure they're 100% correct. Integumentary system and its role, basically the skin, and it's to protect the body from infection. What is the leading cause of bradycardia in pediatrics? Respiratory issues and hypoxia. Generally, you're not going to see a ped who's having cardiac only issues. It's normally respiratory that causes cardiac related issues. But with medicine, there's no absolutes. So, don't go sending your sails without, having an idea of what's exactly going on. Croup signs and symptoms as well as its epidemiology. So seal-like bark cough, this will present with a lower grade fever, upper respiratory viral infection, results in inflammation of the trachea and all that good stuff, all the way up to the epiglottis, and the oropharynx and above. And when it gets inflamed, obviously, you hear the seal-like bark cough. This will also present with dyspnea in your pediatrics. So yeah, what type of bleeding requires direct pressure as well as a tourniquet? Arterial bleeding and at least 2 inches above. Arterial bleeding is bright red and it will spurt. Contrary to popular belief, venous bleeding is not blue. Your veins are blue because they're blue. So yeah, signs and symptoms of meningitis, stiff neck, nuchal rigidity, the same thing. Red rashes, high-grade fever. Peds, you'll see that they want nothing to do with their mom, which with a pediatric, that is no good. That's very bad. They generally don't want strangers touching them and talking to them, and if they are letting that happen, something is really wrong. And meningitis is the meninges in the brain are inflamed by a viral or bacterial infection. Bacterial tends to be more acute, whereas viral tends to be more chronic. APGAR, I will go over later APGAR scores and how they exactly work. And what is the course of action if the kid is cyanotic in color and they're in their extremities only and crying. So that would be a 9, and you're gonna warm and dry vigorously to regain that stimulation. How to treat an allergic reaction, and what is the primary concerns versus anaphylaxis. Epi, if the patient has it, or O2. Anaphylaxis quickly turns into shock. An allergic reaction can be very minor, but it can be a sign and a prerequisite to anaphylaxis. Anaphylaxis is the end game, and anaphylaxis can be easily fatal. When do we consider chest compressions in a newborn? What is the normal heart or the normal vitals, and what should we be confused with, or what concerned with? Sorry. Heart rate less than 60 will result in CPR. Reps less than 30 plus, respirations less than 30, pulse less than 100 start giving BVM. Signs and symptoms of a ruptured spleen in a child: sharp pain, left upper quadrant to the left shoulder, low blood pressure, high heart rate, rigidity or distension, possible ecchymosis. Signs and symptoms of epiglottitis: that's inflammation of the epiglottis, sore throat, drooling, bacterial infection of the epiglottis, high-grade fever. After the head of a newborn is delivered, what should we observe that would indicate a possible respiratory complication? Green, yellow, brown incontinence that can be asphyxiated by the child. This is also known as meconium. Basically, when the baby's coming out, he takes a big fat shit, and then he eats it all up, and now he's aspirating on it. And that can be a very, very rough start to life. When and why do we place newborns at the level of the placenta of the vaginal opening? So think about it. It's like treating for shock. You want to put the person right next to, well, it's basically the mom's still the heart if the cord's pulsating. So you want that baby as close to it as it can be, and you want them so that all that blood come right into the baby. And you can stop doing that once the baby's cord stops pulsating, if that makes sense. Regardless of any type of traumatic injury, if the patient is unresponsive, our first priority is carotid pulse, ABC, life threats. Best way to treat for frostbite on extremities would be warming passively. Don't warm too quickly. Frostbite, if you warm it too quickly, that can result in a lot of bad deals, and that's not what you want. You want to warm passively, like a blanket or something, and you just want to slowly return it to temperature, because if you start massaging it, put it in hot water, etc., you're going to cause a lot more problems in the long term, especially even in the short term too. Gunshot wound victim with injuries to the thoracic cavity becomes increasingly short of breath. Can we assist the patient? Inclusive dressing, ALS will help, and they will pop them with a chest tube, because that can either be a hemothorax or pneumothorax. But yeah. When to treat a puncture injury to the chest wall, how do we place a semi-occlusive dressing? So 3 dressings of the wound are covered, and then you want the bottom out. This will allow for air to come out, no air to come in, which is what you want. Head injuries and blood thinners, why are they such a bad combination? And how many of the patients patient present? Head bleeds a lot normally because there's a lot of vessels and shit in the blood, or in the head, sorry. And blood thinners cause problems clotting. This will pretty quickly turn into posturing, Cushing's triad, and an altered LOC. Obviously, ALOC, Cushing's triad, posturing. If they're still decorticate, you've got a chance. If they're decerabit, diesel therapy and a neurosurgeon is about the only thing that's going to help them at that point. When we are seeing bubbling and bleeding from a penetrating chest injury, What is the best dressing for it? Semi-occlusive. When you're seeing that, that means blood is getting asphyxiated and or it's being brought into the areas in which oxygen is supposed to be, and that is no good. You want that out of there, because that can cause a lot more problems than we would like. Main difference between a femur fracture and hip dislocation. So when the thigh gets snapped with the femur fracture, you're gonna get a deformity to the thigh, and it's gonna be swollen to shit. Hip dislocation will generally not present with either of those. How do we treat an open femur fracture? Pressure or a tourniquet, stabilize with manual splint, or cover with ABD pad. You do not use a traction splint in an open femur fracture situation. It's just a no-go. That's one of the contraindications. If you're using traction splint, it needs to be closed, and it needs to be a midline femur fracture, and that needs to be the only wound. If a knife is impaled into a bony structure on the sternum, what do we do with the knife? Stabilize unless CPR is necessary, then remove. There has been a lot of debate when I was in class about that, and I don't know. It sounds pretty crazy and metal, but I guess it makes sense in its own weird way. Signs and symptoms of pulmonary contusion. What type of injuries are these caused by? Coughing of blood, bruising, difficulty breathing, normally associated with traumatic injuries. It's contusion. That goes under DCAP BTLS. Contusions are generally, it's the second one in your DCAP BTLS, and that's generally, that's trauma related. Signs and symptoms of aortic dissection. What is the epidemiology? Unequal pulses in the limbs. Sharp tearing pain, uncomfortable, they cannot sit down comfortably. Sense of impending doom, because, I don't know, the biggest part of their body, the garden hose of blood, just got dissected. Aortic dissection can be due to trauma or medical. In the medical situations, generally very similar to a hemorrhagic stroke. There is a part of the wall, well, not very similar, sorry, but there is a part of a wall that basically starts filling up with blood. Once that dissects, all that blood comes skirting out, and that's no good. How do we position a patient with a nosebleed? Lean forward, pressure on the nose. They can generally throw up and shit, so don't lean it back. Leaning it back will just make them more prone to throwing up. How do we position a patient with a nosebleed? Rules of 9. Burns to an arm. Arms are 9, chest is 18, back is 18, leg is 18, head is 9, groin is 1 for an adult. The head is 18, and the legs are 14 for a pediatric. A laceration to a medial aspect of the neck. Medial aspect of the neck. Worried about subcutaneous emphysema. What type of dressing would be most appropriate? Occlusive dressing. You don't want any of that air getting in. What are recommended landing zones for air? Medical. 100 by 100. So 100 by 100 feet. Remember that. A patient presents with acute status cardiac symptoms. Is delaying getting on the gurney. What is the best course of action? Give them O2 and explain the dire consequences to their actions. You do not want to just give them the AMA and say, well, go fuck yourself, because that's not coming back on you. That's coming back on your paramedic, and that's no good for anybody involved. When do we consider requesting additional resources, multiple patients, and safe scene? If more than 2 can't handle the call for additionals, contact dispatch. So always when you're doing the FISDAP testing, think of it as you and Joe Schmo, your buddy, only BLS level buddy, arrive on the scene, right? That's all you got. You don't got any more. The rest is additionals.
Best way to remember things: crime scene or sketchy, scary, bad. Related to people, that's going to be your police involvement. Sketchy, scary, bad because of utilities like water, electrical, any of that good stuff. That's going to be your power utility company. If it's going to be anybody at all who is entrapped or there's a fire or any of that good stuff, that's going to be your fire department. And if it's just too many damn patients, then that is going to be your additional resources from your paramedic company or your paramedicine company or fire department. Place bloody clothing in a brown paper bag if a sexual assault victim or if this is some sort of evidence, because Ziploc or plastic, well, no good. That's not what you want to place things in. Do not resuscitate paperwork. It needs to be present to follow DNR protocols. What do we do if they are not? Continue CPR and life-saving measures. What is quality improvement in relations to EMS? Better improving of the agency. If you're an actual EMT, that's completely off, but for the test, that's what you need to say. Okay? When would we consider rapid extrication even if C-spine is indicated? Immediate life threats. This goes back to your good old cars on fire stuff. They're dying immediately stuff. That good old stuff. But normally just if the car's on fire or something like that. What BSI PPE should we consider wearing if a patient has profuse bleeding? Gloves, mask, oh god. Gloves, mask, goggles, sorry. I gotta correct that. Oh boy. Oh no. I don't know how to spell goggles. Consider notifying law enforcement with unusual circumstances surrounding the death of a hospice patient. Intentional overdose. I mean, if there's someone who died at a hospice hospital, they want to die, so probably not going to be your number one thing, but the test will say intentional overdose. If any scene just flat out doesn't make sense, call PD, because it's better that they investigate something that doesn't make a whole lot of sense than not, and the murderer gets away. Only competent adult over the age of 18 may refuse treatment and transport regardless of illness or injury. If they are emancipated or they have a kid or they're married, can make decisions on their own, have to be ANO times 4. So if you've got a patient who's ANO times 3, no, sorry, you're going to the hospital because you are not competent enough to make your own decisions. ANO times 4 is the requirement for any sort of AMA, any of that good stuff, because if someone's got a myocardial infarction and they're dying, you are in their ANO 2 and they're saying, don't take me to the hospital, it's too expensive. Tough shit. So, yeah. When considering requesting heavy rescue tools such as, Jaws of Life, no one calls it Jaws of Life, they call it the spreader or the cutter. It is Hollywood that calls it Jaws of Life. This is used in entrapment or extrication of a victim from a situation in which you guys cannot do that without. When treating a patient that will need transport, what should we do with the minor on scene? Transport in the front, there is little car seats for them, or call PD, and PD will take care of them. When lifting a patient using a power grip, how many inches should our hands be apart? 10 inches or 25 centimeters? I don't know what the power grip looks like. You're going to have to Google that. What colors does black on the triage tag represent? This goes back to your start cards. This means deceased, apneic, or pulseless. Some more grim ones will say morgue, but yeah, all means the same, dead. Does anyone hear our sirens while driving code, or does everyone hear our sirens while driving code 3? How should we proceed through intersections? No, not everyone does. Cautious, proceed once safe. If you're on the test, there is no such thing as being too safe. So always choose the one. In California, maybe even nationally, I believe it's 15 miles an hour that you have to be, that you can go across a intersection. But I think it might be even less than that in most places. And I know some ambulance companies, you have to come to a complete stop. Does everyone hear our sirens? Oh, sorry. How do we correct an error on our documentation? Accepted legal form of correction. Line through, organized, horizontal. Initial and date. If online, make an addendum. Of the hot, warm, and cold zones during a hazmat incident, which zones would be best for EMTs to triage? Cold zones, cold zone, cold zone, cold zone. Think about it. If any of you remembered back in like 2016 with Ebola, all that good stuff, there was a book that was released around that time point called The Hot Zone. It was about the Marburg virus and the Ebola virus. Spoiler alert. Basically, the guy goes straight into the fucking hot zone where the patient 0 is and all that good stuff. You do not want to be in the hot zone, if at all. No good. Cold zone's where it's at. Even though if you're in the cold zone, still maintain and observe standard practices of the hazmat incident. You don't want to just be sitting there buck-ass naked and saying, oh yay, giving me all the bad stuff. Examples of community relations in EMS would be public classes for CPR or public education or outreach. If you walk into a patient's house and let's say it's old Graham and she's got old wooden stairs and she falls a lot, I suggest she gets a carpet, that kind of stuff. Don't be shitty, don't be an asshole, be nice, treat someone like they're your family. So, next up, we're going to move on to a few smaller things. About trauma. So, life threats always take over ABCs. There's no question about that. So yeah. So right now we're gonna go over the yeah. So this is actually a pretty cool little photo here. So though she did die in the end, she was a nurse, and this is one of the only photos that you can really see a person with decortibrate posturing. As you see here, that is someone who got struck in the head by a piece of cement, immediate head injury, and yeah, the body's natural response is to defend itself, and as you see here, it's trying to defend itself. And remind you, this video was immediately taken after she fell, or after she got hit, which I thought was kind of nuts. How crazy how quickly the body responds to that. Actually, what? Oh, that's the certibrate is also that's quarterbit. Quarterbit's inside, certibrate's outside. As you see here, the body's not defending itself. No good. Very bad. Generally means someone's probably pretty close to death. So yeah. Next up, Dr. Germ. Oh, not good. My bad. Dr. Germ, EMT. Study acronyms. So when you're dealing with the okay, there we are. Stop, I don't care. Where's Dr. Germ? Okay. The No! Dr. Germ. This is the best way to deal with abdominal problems. So when you're palpating the abdomen, especially you got big hands, don't go doing the fucking dolphin procedure. Use the tips of your fingers and feel for it. But distension, rigidity, guarding, evisceration, rebound, tenderness, and masses. Another thing with trauma assessments, people stop at the butt way too often. You want to go down to the legs, because at the legs, there could be a lot of different things that cause that wound or cause the trauma. So you want to check them regardless. Along with that, decap BTLS, deformity, contusion, abrasion, punctures, penetrations, burns, tenderness, laceration, swelling. Always remember that stuff. So yeah. Um, CSM, uh, yeah, that's circulation, sensory motor. That's something you probably should have hopefully learned by now. OPQRST is not that hard. HAM is what I'd suggest. That is history, allergy, meds. So yeah. So right now we're gonna go over a like quick little like I guess you could call it like call. So um, let's say we've got a patient at the gym. Um, they are complaining of chest pain, and you arrive on scene, uh, and it's like 3:30 in the afternoon. Uh, you get to the gym, and you see the patient. So yeah. In the comments, give me an answer to that. I will give additional information, and I will help you determine the call. One more time, that will be you've got a medical, presumably call. You're responding to a patient at the 24-hour fitness, and you arrive on scene, and you see the patient is holding his chest. That's about it. Alright? So, if you guys have any additional questions, need any more help, I'll be posting a few more videos here throughout the day. Please comment and ask questions. If I got any information wrong, please notify me. I will gladly change the information. And have a wonderful day. Good luck studying, and best of luck on your testing. Goodbye.